And good afternoon, everyone. Thanks for this invitation to speak with you about the new guidelines for perioperative management. They were released late last year. I've long thought that perioperative care is one of the most interesting and inherently multidisciplinary aspects of our cardiology practice. And although I'll be talking about the guidelines, what you'll hear today are my own opinions rather than necessarily the committee's or the sponsoring organizations. But before we delve into the new guidelines, I wanted to say a few words about how I got involved in this process, both because multiple people have asked me that question and because I think it's an object lesson in the importance of both sponsorship and staying open to new opportunities. You see on this slide a timeline of ACC/AHA guidelines for perioperative care around non-cardiac surgery, all the way back to the original 1996 guidelines chaired by Dr. Kim Eagle to the late 2024 version that we're going to discuss today. And in the early 2000s, a young faculty member and outcomes researcher at the Brigham was establishing herself, certainly working in and publishing about perioperative issues, like the paper I flagged here, but also certainly not considering herself an expert. Nonetheless, I was invited by AHA and ACC to join Dr. Eagle's committee for the revision of the 96 guidelines, having met Dr. Eagle at Mass General during my fellowship interviews and stayed in touch since. So I said yes to that invitation, little knowing that it would lead to a 20+ year involvement with the guidelines, including chairing an update on the then quite controversial issue of beta blockade in the wake of the publication of the POISE trial, and vice chairing 2 other iterations of the guidelines. To our fellows, I would just say that although this represents an enormous amount of time and work, it's also one of the best things I did in my professional life. And I would certainly encourage you, if you have the opportunity, to become involved in our professional societies and to get involved with any statements or guidelines in which you have an interest. So I think we all recognize the problem that these guidelines are trying to address. It's estimated that over 300 million non-cardiac surgeries are performed worldwide each year. And overall, approximately 3% of those individuals will experience major adverse events, including death, non-fatal MI, or stroke. But that risk is quite variable, dependent on both patient factors and the type of surgery, with vascular procedures typically being associated with significantly higher risk. To help us understand that better, my fellow vice chair on the 2024 guidelines, Nat Smilowitz, and his colleagues published this analysis of major cardiovascular and cerebrovascular events by type of surgery. And you can see that the spread of risks is quite wide and peaks at almost 8% for those undergoing vascular surgery. Why do we see this heightened risk in the perioperative period? Well, clearly non-cardiac surgery acts as a strong cardiovascular stressor. Non-cardiac surgery has been associated with heightened catecholamine levels, elevations in heart rate and blood pressure, increased myocardial oxygen demand, and a tendency to arrhythmia. It also engenders a heightened inflammatory response with effects on both plaque vulnerability and rupture. So in that setting, today we'll discuss the role of the consultant, review the new proposed pre-op evaluation algorithm from the 2024 ACC/AHA guideline, and importantly, some of the data underpinning its recommendations. We'll also touch on some of the data on preoperative revascularization and the timing of surgery, medical therapy, most notably beta blockers, myocardial injury after non-cardiac surgery, and some of the new recommendations regarding periop AFib. I think it's important to mention at this point, though, that these guidelines are really meant as a synthesis of evidence with the intent to improve quality of care and hopefully align with patients' interests. But they are only that. And the preamble explicitly states that they should not replace our clinical judgment. As a consultant cardiologist, we're often asked to risk stratify the patient's cardiovascular risk of surgery, taking both patient and surgical factors into account. We then try to make recommendations to minimize that risk with medications, monitoring, and actually quite rarely intervention. Perioperatively, we're often called in to assist with managing cardiac complications like ischemia or atrial fibrillation. But importantly, I believe we're also there to assist with future risk modification, as this is sometimes the only time that that patient sees a cardiologist. This is figure 1 in the 2024 perioperative guideline, which outlines a stepwise approach to perioperative cardiac assessment, AKA the algorithm. The suggested pathway is not meant to address every perioperative clinical situation, but rather is a general guide supported by the writing committee after hundreds of hours of literature review and discussion and decades of accumulated perioperative clinical experience. And again, it should not supplant sound clinical judgment, or as our chair, Dr. Thompson, reiterated, treat the patient, not the guideline. Focusing in on the upper portion of the 2024 Periop algorithm, it's actually quite similar to the 2014 version. It focuses on patients with cardiovascular risk factors, disease, or symptoms undergoing non-cardiac surgery. And because what we do perioperatively is inextricably linked to the timing and urgency of surgery, the first question it asks is if that patient is undergoing an emergency surgery, which is defined as threat to life or limb requiring emergent intervention, often within 2 hours. I tend to think that my role in these types of situations is to do whatever clinical evaluation is possible in the time available, make any recommendations to lower risk, knowing that the evidence suggests that emergency surgeries are associated with higher cardiovascular risk of complications, and then flatten myself against the wall of the hallway so the gurney can roll by on the way to the OR for a life-saving procedure. The second box asks us to contemplate whether the patient has an active cardiac condition that should generally make us stop and consider whether to proceed to surgery. And in 2024, those active cardiac conditions include acute coronary syndromes, unstable cardiac arrhythmias, or decompensated heart failure. The next section addresses the cardiovascular health of the patient with an enhanced approach that uses both a validated risk calculator as well as additional conditions or situations that may contribute to negative perioperative cardiovascular outcomes or require special attention. And this is new since the 2014 guidelines. Delving in a bit deeper, as in 2014, the writing committee advises use of a validated risk calculator to assess the perioperative risk of the patient with a 2A recommendation, meaning that the benefits are felt to outweigh any risks. Multiple validated risk calculators are listed here and compared and contrasted in the document, and no one risk calculator is recommended over another. Based on my own practice, the RCRI is probably the most commonly used, but each has its pros and cons. The algorithm also includes a number of risk modifiers, that is, cardiovascular conditions that may not be adequately accounted for in the traditional risk calculators and that can be used concurrently with them. To address this gap, the committee suggests also looking for conditions such as severe valvular heart disease, severe pulmonary hypertension, frailty, the presence of a pacemaker or ICD, prior coronary stents or cardiac bypass surgery. And these risk modifiers are new since the 2014 algorithm, making it perhaps a little bit less focused on ischemic heart disease and broader in scope. One very important point is that if patients score as low risk without risk modifiers, they can proceed directly to surgery without any additional testing. The idea, of course, being that for low-risk situations, it's hard to lower that risk any further, no matter what you do. But as my colleague, Dr. Redberg, likes to remind me, that's not always how we practice in real life. For example, this New England Journal article looked at preoperative testing around cataract surgery, generally acknowledged as a classic low-risk surgery with a less than 1% risk of MACE or death. It also happens to be the most common elective surgery in the Medicare population. And in this random sample of almost 500,000 people undergoing cataract surgery, a majority had had at least one pre-op test, including 163,000 EKGs, almost 12,000 echoes, and almost 18,000 stress tests. If, on the other hand, the risk calculators suggest elevated risk, which often means that these individuals have risk factors for cardiac disease, then the algorithm supports consideration of an ECG and standard goal-directed medical therapy for risk reduction. And if risk modifiers are present, you might want to consider an ECG or possibly echocardiography along with that standard GDMT, depending on the situation. For example, echo is recommended when there's suspected significant valvular stenosis or new dyspnea or suspected new or worsening ventricular dysfunction. Well, at this stage, we know quite a bit about the patient and their risk. We know that the patient doesn't have an active cardiac condition, but does have an elevated risk of perioperative cardiovascular morbidity as identified by risk calculators or the presence of risk modifiers. But what can that patient do physically? Just as in 2014, functional capacity of patients is still very important in this guideline. But the new guideline supports the use of structured assessments, such as the DASI questionnaire or METS levels, to determine if the patient has impairment of functional capacity. I think that's because we've learned a bit more about what works in functional status assessment in the interim. For example, in this Lancet article from our Canadian colleagues, about 1,400 patients undergoing major non-cardiac surgery were assessed in 3 ways. By the anesthesiologist's subjective estimation, broken down as less than 4, 4 to 10, and more than 10 METs. By the Duke Activity Status Index, or DASI, which is a validated 12-item questionnaire, or 3, cardiopulmonary exercise testing, which is actually used substantially in the UK and Europe for preoperative assessment. What they found was quite interesting in that the DASI score, but not subjective estimation by the doctor, predicted death or MI, perhaps because the correlation between subjective assessment and CPET, which of course gives you a quantitative MET level, was limited, with only 19% sensitivity for greater than 4 METs. For those of you who may not be familiar, this is what the DASI looks like. It's self-administered, takes a minute or 2 to complete, can even be done before the visit. As I mentioned, it seems in some studies to be more predictive than doctors' estimates, and the higher the score, the higher the functional status. And for the purposes of the guideline, a cut point of greater than 34 is associated with a lower risk of complications. So if the patient has excellent or even moderate functional capacity, they can generally proceed to surgery without further testing. If, on the other hand, there's significant impairment of functional capacity, then the question becomes, would further testing impact your patient care? And if the answer is yes, that further testing could likely change the course of treatment, then you enter this 3rd stage of the algorithm, which is revised from 2014 and incorporates biomarker assessments as a way to further risk stratify patients when functional status alone won't do. The algorithm lists both BNP-related markers to assess for wall stress and heart failure, as well as troponins to assess for ischemia. But to my mind, the data for BNP and pro-BNP are much stronger. And you'll notice that that's supported by BNP receiving a 2A recommendation, while preoperative troponins receive a much weaker 2B recommendation. To help us understand where that recommendation, particularly for BNP-related biomarkers, comes from, we need to review a large cohort study conducted by our Canadian colleagues called VISION, that's new since the 2014 guidelines. It enrolled over 10,000 individuals, 45 or older, worldwide, who were having inpatient non-cardiac surgery. And the protocol called for preoperative determination of NT-proBNP, as well as post-operative troponin T levels daily for up to 3 days, depending how long you were in the hospital. And what the investigators found can be summarized in this chart. There was a strong association between pre-op NT-proBNP levels and a combined outcome that included vascular death and an entity called MINS. And we'll talk about MINS in greater detail a bit later, but it's essentially characterized by abnormal elevations in troponin postoperatively, felt to be ischemic in nature, whether or not criteria for MI or ACS are met. Clearly, in this study, the higher the pre-op BNP level, the more likely this combined primary endpoint became. And in case you're not sure about MINS as an outcome yet, here's a similar graph plotting the NT-proBNP levels and mortality, a hard endpoint to be sure. And again, one sees a consistent stepwise progression in risk, suggesting that biomarkers can be used to help stratify our patients further if functional status alone won't do. As a matter of fact, the Canadian guidelines, which were issued in 2017, have gone all in on biomarker testing, with their algorithm focusing on older adults or younger ones with CVD who are undergoing surgery requiring an overnight stay, which effectively excludes most low-risk surgeries. And in their algorithm, if surgery is elective, they suggest performing clinical risk stratification, including an RCRI score. And if you're older, or your RCRI is 1 or more, or perhaps you're younger but have significant CVD, then the recommendation is to order a BNP or proBNP, and based on those results, to consider post-op troponin screening or shared care. Getting back to our own AHA-ACC algorithm, though, if the biomarkers such as BNP to detect wall stress and heart failure, or CTNI to detect myocardial injury are normal, then the recommendation is to proceed to surgery. But if they're elevated, here's another time for multidisciplinary discussion regarding risks, benefits, and additional cardiac evaluation. And if the answer is yes, that further testing would likely change the course of treatment, then you certainly can consider further non-invasive testing, including echocardiography, non-invasive stress testing, or CCTA, depending on the specific situation. And if those are negative or demonstrate low-risk findings, then the patient can generally proceed to surgery. However, if any of those show elevated risk, at that point, the team can consider and discuss alternate strategies, deferral surgery, non-invasive or invasive treatment, or palliation. Now, CTA is making its first real appearance in this algorithm because we didn't have that much information about it in the peri-op space for the 2014 guidelines. But we know more now, in part, again, thanks to our Canadian colleagues, who conducted a prospective cohort study of close to 1,000 patients, 45 or older, with or at risk for atherosclerotic heart disease. They all underwent CTA, looking non-invasively at their epicardial coronary anatomy, and results were grouped into basically 4 buckets: normal, non-obstructive, obstructive, which was defined as 1 or 2 vessels with 50% or more stenosis, and finally extensive obstructive, which included PROX-LAD disease, multivessel, or left main disease. Overall, 8% of this cohort had death or MI, so fairly high risk. And in multivariable analysis, CTA results added independently to clinical stratification with the RCRI. Here are those data presented graphically for those of us like me, who prefer to see things visually. But the graph also points out some of the pitfalls here. For example, almost a third of the events occurred in those with normal or non-obstructive findings, suggesting that you don't need a 90% lesion to have a problem post-op. And what's more, when they looked at reclassifying patients by their CTA results, they found that one was roughly 5 times more likely to reclassify someone as higher risk who ultimately would not have an event than to reclassify someone as higher risk who ultimately did have an event. As a related issue, you might have noticed that stress testing comes up much later in the current algorithm than before. In my own opinion, because it's been hard to show that more stress testing leads to better outcomes. And it brings up the sticky question, namely, who is most likely to benefit from preoperative testing? At this point, I want to hearken back to an op-ed written by our own Dr. Gabe Gregoratis, an enormously astute cardiologist and clinician who ran our consult service for many years. He opined over 15 years ago that patients with symptomatic CHD undergoing higher risk surgeries, or asymptomatic patients with poor functional capacity or diabetes undergoing those same types of surgery, or perhaps those with poor functional capacity and multiple risk factors undergoing vascular or equivalently high-risk surgeries might be the sweet spot for testing. But that equation also depends on a number of underlying assumptions or issues that we're continuing to learn about. For example, does pre-op revascularization really decrease perioperative complications? And for that matter, what are the risks of preoperative intervention, both in terms of stent thrombosis if antiplatelet agents can't be continued, and in terms of timing of surgery? And do we have effective medical therapy, most notably beta blockade, to reduce perioperative cardiac events? In this regard, I just want to touch on a seminal trial by Ed McFalls, with whom I had the pleasure of working in Europe early in my career. And although there have been subsequent trials, the CARP trial was really the first major trial to call into question the paradigm that pre-op revascularization would reduce ischemic complications. Recall that this was a VA-based study of 510 patients undergoing vascular surgery. Everyone underwent angiography. They all got cathed. And everyone enrolled in the trial had at least one major vessel with a 70% or better stenosis. Although importantly, those with left main disease, severe cardiomyopathy, or significant aortic stenosis were excluded from randomization. They were randomized to pre-op revascularization or no revascularization. And the mode of revascularization, that is CABG or PCI, was left to the discretion of the treating team. And here's what they found. Perhaps unsurprisingly, revascularization delayed surgery, an average of 54 days for those undergoing CABG and 18 days for those with PCI. And revascularization was actually associated with more preoperative deaths, including some associated with the revascularization itself. But what surprised everyone at the time was that revascularization did not appear to prevent perioperative MI effectively, nor did it improve post-op mortality. These data have led to the following recommendations regarding revascularization. First, a class 1 recommendation for deferring elective surgeries and revascularizing as you normally would in patients with acute coronary syndromes. Second, a 2A recommendation to defer surgery and pursue coronary revascularization in those with significant left main disease in chronic coronary disease. But otherwise, routine preoperative revascularization in order to reduce complications carries a class 3 no benefit tag. A second important factor is the risk of pre-op PCI, and as a related issue, the timing of non-cardiac surgery when that surgery often interrupts antiplatelet therapy. The concern early on was from data like these, from a large VA database looking at the cardiac results of non-cardiac surgery that occurred in the 24 months after stent placement. And in this cohort, roughly half of the PCIs were bare metal stents, the other half drug-eluting, and they looked at a primary outcome of 30-day MACE. The incidence of MACE was highest if surgery was performed in the first 6 weeks after surgery, then decreased steadily from there before flattening out around 1 year. So now we obviously use almost exclusively drug-eluting stents, and subsequent generations of stents are felt to have much lower thrombosis rates, so that we've gradually shortened our recommendations for DAPT over time. Nonetheless, I would say that these new guidelines err on the side of caution, if you will, giving the nod to proceeding with non-cardiac surgery that requires management or interruption of DAPT 2 weeks after a balloon angioplasty, a month after bare metal stenting, 6 months after PCI for chronic coronary disease, and 12 months after DES placement for an acute coronary syndrome. That's more conservative than some of our recommendations outside the perioperative space. But my own take is that the committee was concerned about fully extrapolating data not generated around non-cardiac surgery to the perioperative space, due to the often prothrombotic milieu that's created around the time of a surgery. Helps us heal, but unfortunately could also help us clot in unwelcome areas. It's also important to note that there are off-ramps here. 2B recommendations that allow for surgery after 3 or more months if the surgery is time sensitive or the risks of delaying are felt to outweigh the risks of proceeding. And as always, use your clinical judgment. And then, of course, there's the question of whether we have effective medical therapies to reduce perioperative cardiac risks, most notably beta blockers. Some of you may recall this New England Journal article by Dennis Mangano and colleagues that randomized 200 patients with or at risk of CAD to atenolol or placebo. Interestingly, the short-term outcomes were not dramatically different in this study, but the long-term outcomes were what garnered all the attention and made it to the New England Journal of Medicine. Specifically, beta blocker therapy was associated with lower mortality at both 6 months and 2 years after surgery, even though, as I recall, the protocol did not necessarily mandate that beta blockers be taken during all that time. And in this large cohort study of patients undergoing non-cardiac surgery, beta blockade was associated with reduced mortality overall. But interestingly, the mortality benefit appeared directly related to the RCRI score, with no benefit and even the suggestion of potential harm in those with an RCRI of 0, but progressively bigger reductions with higher RCRI scores and therefore higher risk. So these types of data led to widespread enthusiasm for perioperative beta blockade. And I recall collaborating with my friend and colleague, Andy Auerbach, who, by the way, also serves on the Periop Guideline Committee, to obtain NIH funding to study the effects of beta blocker implementation on outcomes. But shortly thereafter, the results of the POISE study were published. And our Canadian colleagues, led by PJ Devereaux, had managed to complete a large multinational randomized control trial of over 8,000 patients 45 or older who were undergoing non-cardiac surgery and were at higher risk due to a history of CAD, PVD, CBA, heart failure admission, major vascular surgery, or the presence of multiple risk factors. Patients were randomized to an aggressive regimen of beta blocker, consisting of long-acting metoprolol 100 milligrams pre-op and within 6 hours post-op, and then another 200 milligrams daily, starting 12 hours after the first post-op dose, as long as hold parameters for bradycardia and hypotension were met. The main outcome was a composite of cardiovascular death, non-fatal MI, and non-fatal cardiac arrest, although they also tracked a number of secondary outcomes that would become very important, as I'll show you. So here are the primary outcomes from POISE. You'll notice in the composite primary outcome line on top that beta blockers actually did what we wanted and expected them to do, which is namely significantly to reduce cardiovascular death and non-fatal MI or cardiac arrest. The problem was with those secondary outcomes. First of all, overall mortality was higher in the metoprolol group. Stroke was also significantly higher in the metoprolol arm. And death from sepsis was dramatically higher when beta blockers were on board, almost 28% to 19%, with hypotension and bradycardia both being significant predictors of death. And so data like these have resulted in the current recommendations in the 2024 guidelines. First, a class 1 recommendation to continue beta blockers perioperatively if clinical circumstances warrant, since there are also data that withdrawing beta blockade in those chronically treated with them can increase risk. Second, a much weaker 2B recommendation that if you have a good indication for a beta blocker, that they be initiated far enough ahead of time, usually a week or more, to assess tolerability and titrate dosage if needed. But a class 3 harm recommendation for initiating beta blockers on the day of surgery in those without an immediate need, for example, an arrhythmia, due to the increased risk of post-op mortality seen in POISE. So getting back to our algorithm, if non-invasive testing is determined to be negative or shows low risk findings, then the patient can proceed to surgery. However, if any of those show elevated risk findings, the team can consider whether to proceed to surgery, alternative strategies such as deferral, non-invasive or invasive treatment, or palliation. They can also consider post-op troponin surveillance, essentially screening for MINS, although you'll notice that this gets a relatively weak 2B recommendation, in my opinion, likely reflecting the wide spectrum of views on this subject. So first, let's make sure we're all on the same page together. Let's talk about definitions. MINS stands for myocardial injury after non-cardiac surgery. And PJ Devereaux, who was instrumental in evaluating MINS, defined it as a myocardial cell injury during the first 30 days after non-cardiac surgery due to an ischemic etiology. An AHA consensus group convened a few years later defined it as an elevated post-op cardiac troponin concentration that exceeds the 99th percentile of the upper reference limits of the assay and is attributable to a presumed ischemic mechanism with or without concomitant symptoms or signs. The rationale, I think, is that symptoms and signs may be masked in the immediate post-op period, but that troponin elevations remain a marker of increased risk, whether or not they meet standard criteria for MI or acute coronary syndrome. Well, I won't dwell on standard management for MI or ACS for this audience, although we all know that standard management can be often complicated by the bleeding risks of the perioperative period. But focusing squarely on troponin elevations that do not meet criteria for MI or ACS, we come to the question, what to do about MINS? Well, standard risk factor management seems reasonable to try to lower that downstream risk. And based on observational cohort studies, it's been proposed that patients with MINS should possibly be prescribed ASA and statins if they aren't already. And there has certainly been interest in other novel therapies for the postoperative period. For instance, there's been interest in the potential role of anticoagulants in improving MINS outcomes. And there's even a single RCT. In the MANAGE trial, Devereaux and his team randomized patients 45 or over within 35 days of their MINS diagnosis, so squarely post-operatively, to dabigatran, interestingly at the 110 milligram dose, or placebo. There was apparently slower than anticipated enrollment, and perhaps as a related issue, the main outcome was broadened during the study to include symptomatic venous thromboembolism and amputation, as well as the cardiac and vascular complications listed. Here are the outcomes. dabigatran reduced composite outcomes by 28%. There were also reductions in death and non-fatal MI, but those were non-significant and, in my opinion, likely underpowered. But there were also twice as many cases of venous thromboembolism in the placebo group, suggesting that a significant part of the benefit of dabigatran was mediated through venous rather than arterial events. Well, as you know, another complication for which we are commonly consulted is atrial fibrillation. And the good news is that it's often transient and eventually resolves once triggers like volume overload, pain, anemia, and the like have either been treated or have died down with time, as outlined in the first 2A recommendation on this slide, especially if there's no antecedent history of atrial fibrillation. And as I recall, when I was in training, that was about it. We saw post-operative atrial fibrillation as certainly a nuisance and often a challenge to rate control, but we were glad that it was just perioperative atrial fibrillation that would hopefully soon revert to sinus rhythm, and we rarely, if ever, considered anticoagulation. We've learned from newer data, though, that atrial fibrillation that starts in the perioperative period can come back in a substantial proportion of patients and unfortunately bring with it an unwelcome risk of stroke. And that's why the new guidelines recommend, with a class 1 recommendation, that patients with perioperative AFib be followed longitudinally and carefully evaluated for whether they require anticoagulation, depending on competing risks of bleeding and thromboembolism or other management decisions. Also new to the guidelines this time around, a class 1 recommendation that SGLT2 inhibitors should be stopped 3 or 4 days, depending on the agent, before elective surgery if feasible, really regardless of whether patients take them for heart failure or for diabetes or other indications, to reduce the risk of metabolic ketoacidosis. So what are my takeaways from these new 2024 guidelines? Well, a few tenets perhaps to remember. Always evaluate for those active cardiac conditions, and now also those risk modifiers that can require special attention. In general, when patient and surgical risk is low, no testing is required. And similarly, when functional status is good or excellent, many patients can proceed to surgery. In general, our screening and treatment should adhere to the same sorts of indications as non-surgical patients, with the special needs of surgical timing incorporated in our thinking. For example, pre-op testing like stress tests should be performed judiciously and generally in the same individuals you test were they not undergoing surgery. Beta blockers are generally continued in those already on them, but try to select patients for new implementation carefully and try to get them on meds well before surgery. Either way, actively manage beta blockade perioperatively, depending on what's going on clinically. Hold SGLT2 inhibitors 3 to 4 days prior to elective surgery if feasible, and recognize that patients with newly diagnosed atrial fibrillation identified during or after surgery have an increased risk of stroke. Follow them closely to assess the need for anticoagulation or other medications. And with apologies to late night TV, there's yet more. We've covered a lot of ground, but it's impossible to summarize a 90-page document in 50 minutes. So I encourage you to take a look at the guidelines yourself, whether it be to review anticoagulation management and the relatively rare times that bridging therapy is still recommended, or whether it's to read about perioperative management of special populations, like those with pulmonary hypertension, ACHD, significant valve disease, implantable devices, the history of previous stroke or TIA, obstructive sleep apnea, or many more. And finally, I'll leave you with this slide of thank yous and acknowledgments to the American Heart Association and American College of Cardiology and our collaborating organizations for sponsoring this guideline, and also for the wonderful slide set from which I borrowed for this talk. To the stalwart members of our writing committee, some of whom called in from the other side of the world to do this work. And to the amazing guideline leadership committee that I had the privilege of working with. To our peer review committee for invaluable feedback, and to Josh Beckman, who chairs the Joint Committee on Clinical Practice Guidelines. And a special shout out to Amy Talbot, our Guideline Health and Science Advisor, who kept everyone and everything on track during the process. By the way, these pictures are from our periop session at the American Heart Association meetings last November. And some of you may recognize the woman taking the selfie. She's Purvi Parwani, one of our former fellows, who was also on the Perioperative Guideline Committee and our social media moderator for the guideline session. So thanks again for the invitation to speak today. Happy to take any questions.
Great overview. So now we'll open up for questions. We have a couple from Zoom, and then for those in the audience, feel free to raise your hand. So start with on Zoom. Nora, Dr. Goldschlager left a comment about neat device recommendation and clearance pre-op by the committee. Dr. Goldschlager, do you want to elaborate more?
Well, Kirsten knows what I'm talking about. We have a history here. It's a great talk. I think omitted from these guidelines, but not necessarily other associations, is a real kind of not just recommendations, but a clearance form that should be devised that allows especially anesthesiology to know what to expect. And for this, I think a little more attention by your committee ought to be given. In other words, is there an underlying rhythm and what is it? What's the response of a device to a magnet? Is there an ICD? What happens? Because we get this, and a clearance if there's time. I think that kind of thing really belongs in this guideline, as well as a preoperative of a good X-ray. And as far as an ECG, you and I don't know, you know how I feel about this, but any post-op, oh my God, what's happening? Is this normal? That really means that you didn't get a pre-op ECG to compare it to. So I'm a big fan of pre-op ECGs as baselines, as you know. So your thoughts?
Yeah, so I'll take the last one first, Nora, and great to hear from you. I know that there were, I would say, spirited discussions regarding electrocardiograms. And so I understand your position. I can tell you that not everyone shares it, and that's the reality. As far as the devices are concerned, there are, I think, at least two outlines in the guidelines that try to walk people through, mostly in conjunction with our own electrophysiologists on the committee, of what to do and what to expect when you have either a pacemaker or a defibrillator. But certainly the idea of a checklist is an interesting one. And thanks for bringing that up.
And we have another question from Dr. Ramsey Dudem asking, curious about how you would approach new AFib diagnosed either in pre-op evaluation or in the pre-op area during surgery. He's seen surgeries canceled for this.
Yeah, it's an interesting question. Thank you. So I think it, as usual, depends on the details. Uncontrolled atrial fibrillation, let's say that AFib with very rapid ventricular rate and such, probably falls under that active conditions moniker, where you really do want to stop and at least consider whether this patient is stable for surgery. And also remember, we've already culled urgent and emergent surgeries out at that point, right? So what I'm saying now applies to more elective surgeries. So if you have the time, you want to make sure that the patient is hemodynamically stable, and also that you weigh risks and benefits with regard to the management of AFib versus the management of that surgical intervention, right? So it's going to be an individualized, I think, decision based on the situation. I don't know, does anybody else have thoughts about that? Mel?
Not that, but I wanted to I wanted to make a comment and ask you a question. The comment is the subsequent risk of AFib occurring during surgery and follow-up is really substantial. We've learned that. And just to emphasize to the audience the importance of the wearable devices that you can put on and follow the patients for weeks. So the guidelines say careful follow-up, but I just want to make it clear, careful follow-up should include these wearable devices. The question I had for you was, CT angio is fantastic, and the practical problem that comes up is renal disease. So can you enlighten us on that? What levels are prohibited, or can you always get around it, or what do you think?
Thanks for that. First of all, I'll say I totally agree with you. Newer technologies help us with that careful monitoring in new perioperative atrial fibrillation, and certainly can be absolutely critical to helping us decide whether the patient needs anything more. So I totally agree. As far as CTA is concerned, and specifically CTA with renal disease, well, there's, I guess, a couple of things to say about that. One is obviously CTA is a diload, right? And in some ways, sometimes a larger diload than a rotational angiogram if needed. But if you think that you can prehydrate, which is the intervention that I think has been best shown to protect the kidneys, and give a diload safely, then CTA is certainly an option. The other thing to say is that, unfortunately, patients with renal disease often have accelerated calcification. And there is the limitation that every CTA starts with a calcium score. And if that calcium score is excessively high, I think usually around 400, Michael Salerno can probably correct me on that, but I think if it's very high, then they feel that they really can't get a good study. So it's also possible that it could influence your test choice on that basis, okay? But I think, to me, the issues with CTA focused more on those things that I tried to point out, which is that, unfortunately, just because your CTA is either normal or non-obstructive doesn't mean that you won't have a perioperative event. That's one thing. And the second thing is that, you know, really what you'd like is you'd like to have wonderful positive predictive value, but also wonderful negative predictive value. Hard to get. But the issue is that you certainly can use CTA to reclassify risk, but there's that 5-to-1 ratio of reclassifying as higher risk someone who ultimately won't have an event. So that's where I have a bit of concern about using CTA preoperatively, but I certainly do it.
All right, and we'll start with Dr. Peter Gans, who has his hand raised, and then we'll go back to.
Hi, Peter.
Dr. Gans, you're muted still.
Okay. Kirsten, congratulations. I was at the Brigham when you started this research, and it's been a wonderful lifelong pursuit for you. Congratulations. I wanted to ask you a specific question about myocardial infarction in these patients and the coronary pathology that underlies it. I looked it up a few years ago, and at least for patients who come to postmortem exam, it's actually no different from the general MIs, plaque rupture, plaque erosion. But that was a few years ago. So what's the latest data on coronary pathology that underlies MIs in this setting? And to the extent that it may be plaque disruption, you did mention statins and aspirin in the MINS patients, but should there be more studies or more focus on preventing plaque ruptures or plaque disruptions in this population undergoing surgery?
Thank you, Peter. And for those of you that don't know, he taught me to cath. So go back a fair way. At any rate, insofar as MI or perioperative MI is concerned, well, you know, that's the sticky wicket, isn't it? We've typically said that a lot of these events are demand-based or type 2 type of events. But as you said, there's pathologic data to suggest that a not insignificant proportion of them are more along the lines of standard plaque rupture events. And so that's where it's sort of the art of medicine as well, is looking at that individual situation, trying to gauge in real time whether or not you're dealing with a type 1 or a type 2 type of event, and exactly what you need to do in medical therapy. I did not dwell on aspirin and statins simply because I did not talk about the management of ACS and MI, but certainly, obviously, if people have underlying coronary disease and an ACS event, they should be on standard GDMT as well.
Kirsten, there's been a common surgical practice to stop ACE and ARB drugs ahead of surgery in the fear of having kidney injury with surgery. Yet there was a study in the last couple of years showing that actually that you created harm because the blood pressure surged up and maybe ruptured plaques and gave you strokes and MIs. So did the committee consider that, and what was the recommendation there?
Yeah. As you already alluded to, there are data to support holding, and there are data to support continuation. And so you'll find some recommendations along both lines. I'm not sure we know 100% the answer there. I would ask, you know, you have a wealth of perioperative experience. What do you do? Yeah. And particularly if you have somebody who's quite hypertensive or has other very strong indications for continuation. But as you said, it's sort of 6 of one, half dozen of the other in terms of the literature. And yes, more information on that would be welcome. Just as it would be great to get more information about the GLP-1 issues, you know, there's been concern about them delaying gastric emptying and such. That's also a story that's being written as we speak, I think.
Kirsten, that was excellent. That was a really nice overview of perioperative management, but also just the process of the guidelines committee. I think that's great to share with fellows. I have a question. You brought up the CARP trial, and I'm often asked about that one, I guess because I was one of the co-authors on it. And people come and ask even when I'm not on service sometimes. And I want to know your take on, you mentioned it, of course, that clinical judgment is so important. It does not get replaced by any of these papers or risk scores or anything. And the CARP trial, as we know, excludes patients with valve disease, critical left main, and everyone had a cath. So I'm often approached by someone who says, we don't need to cath this guy because of the CARP trial. And so that's the first part of the question. The other is the revasc that we're often pushed into doing for other stuff, liver transplants, renal transplants, other things with no data that it actually helps. So can you comment on those two scenarios from the guidelines committee or your clinical
So I can't comment on anything from a guideline committee standpoint because I'm just me. But as far as CARP is concerned, Rick, you bring up an excellent point. And I tried to emphasize that everyone got an angiogram in CARP. And so I think of CARP as informing our practice regarding revascularization, not informing our practice regarding the need for testing, right? I mean, it indirectly, obviously, affects or influences that. But I think of it more as an RCT of what revascularization does or does not do for us, rather than using it a priori to say, well, we don't have to test because of this, for exactly the reasons that you brought up. And I'm sorry, the second issue was, so I think, I'm not sure I know the perfect answer, Rick. I can tell you that, we don't have, as you mentioned, great information on how testing and revascularization influences outcomes in those populations. And there is additional concern from our colleagues of having a scarce, organ that they want to make sure goes to a good recipient. But I'm not sure I have a perfect answer on that. All I can say is that at least for most non-cardiac surgeries, and that's not usually the liver transplant or the kidney transplant, the data are not strong for pursuing preoperative revascularization to reduce complications. And that's, I think, all you can do is have those multidisciplinary discussions with our colleagues, recognizing that, all of us are going for the same thing. We all want a good outcome for the patient. We just come at it from different perspectives and with different risk and benefit calculations.
All right, thank you. Thank you, Dr. Fleischmann, for your time and the great talk. And thank you, everyone, for joining.
My pleasure.
That was really excellent.
Thanks.